We now move on to session 2, towards zero, from regulation to innovation. This session commences with our colleagues from Western Australia, who have been leading the way with relational feedback in Australia since 2016. And we are fortunate to have an all-star lineup to speak to the vision for the consumer voice in WA, Western Australia. I will now introduce all of the speakers together so that I don't interrupt their presentation. First up, we will be hearing from Fran Dowling, who is the current Director for Health Networks within Clinical Excellence Division at the Department of Health WA, having only recently joined after working in a variety of senior health services improvement roles since 2006. And as a former nurse, midwife, and social worker, Fran is passionate about new and innovative ways to optimise patient experience and support truly person-centred care, as well as supporting clinicians to deliver equitable, accessible, and supportive healthcare. Fran will be providing us with a background of how Care Opinion came to be working in every public hospital in Western Australia, and how this is looking post-COVID. And you will hear throughout our program that in aspiring for a safer and happier experience of healthcare, the experience of staff must also matter. And it'll be really good to hear from that. I also have the great pleasure of introducing our second presenter from the WA team, Dr. Tina Bertoloni. Tina is the current Executive Director for Patient Experience and Clinical Excellence at the North Metropolitan Health Service, having joined recently after 8 years working in safety and quality in the Department of Health, and as a former GP and now public health physician with a subspecialty interest in patient safety and quality improvement. She is passionate about new and innovative ways to optimise patient experience and support person-centred care, as well as supporting clinicians in clinical outcomes measurement, quality improvement, and other methods that support the culture for clinical excellence. Tina will be providing the Western Australian Health Service and clinician safety and quality perspective in her presentation today. And we cannot have a conversation about the consumer voice without consumer voice within WA. And I also welcome the Executive Director of Health Consumers Council, Claire Mullen, who will also join the WA team in the presentation this afternoon. Claire has a background in change management and communication in health and community sector in the UK and in Australia. Familiar with workings in WA Health through various roles with health networks and the safety and quality teams. She brings her passion to every interaction and is dedicated in creating opportunities for people who use the health system to be part of shaping it and to improve health outcomes for all. Claire will provide us with a vision of for consumers as partners in safety in WA. Please welcome the team from WA.
Thanks so much, Tina. Hi, everyone. I'm Fran Downing, as Tina introduced. Can we move on to the next slide, please? So, as Tina mentioned, I'll be presenting from the Department of Health perspective. Claire will be from the Health Consumers Council, and Tina will be from the North Metropolitan Health Service, which is one of our health service providers. Okay, next slide, please. Before I begin, though, I'd like to acknowledge and pay my respects to the Noongar Whadjuk people upon whose land I'm meeting with you today, and pay my respects to their elders past, present and emerging. I also want to recognise the significant importance of their cultural heritage, values, beliefs and self-determination in contributing to the positive health and well-being of our community. I also extend my respects to those that are Aboriginal and Torres Strait Islanders present today in this conference. And also just like to let us acknowledge that we celebrate their culture every day, and note how privileged we are to share this country. Thank you. So as Tina mentioned, I'll be presenting on background and context. Then we'll have Tina presenting from a health service provider perspective, safety and quality context, and then we'll have Claire looking at the strategic vision for consumer collaboration in WA. So just to give you a bit of background, so this just shows the public health system. I'm in the Department of Health, which is considered a system manager, and underneath that, sitting in this structure, is 7 health service providers. I've mentioned Tina is in the North Metropolitan Health Service that you'll see there as the first health service provider listed. But this doesn't represent the private health sector, nor does it represent the community health sector or peak bodies such as the very valuable Health Consumers Council, where Claire will be speaking from that perspective today. Okay, next slide. So just to give you a bit of a background to the journey so far in WA, in 2017, Care Opinion was endorsed as a state tool to support patient experience. It was a state government election, and that was based on the findings of a pilot that was in 3 country areas or rural areas in the Kimberley region, Midwest and Great Southern region across WA. In July 17, so 6 months on from the initial election commitment, all health service providers became subscribers to Care Opinion and began responding to stories about their services. And then from 2019, all Care Opinion reports were publicly released so that it was publicly available on a quarterly basis across the system. Click next. And then we can go next slide. Thank you, Alicia. So just to give you a bit of a snapshot of the last full quarter that was reported, across WA, there were 359 stories published. There's over 1,300 staff that are prescribed currently to Care Opinion. The response rate to those stories was quite high at 98, nearly 99%. And you'll note there that the number of stories leading to change doesn't seem that much at first glance, but that's to pay note to a lot of the stories, as James and Fraser mentioned earlier. Overwhelmingly, we get a lot of positive stories in WA. Also, some of them are behavioural changes in terms of staff behaviour that aren't actually captured here, because how the change is sort of captured is based on process changes across the system. So it doesn't really reflect the effect that Care Opinion has on our system. Next. So in terms overall, over the last quarter, the positive experiences overwhelmingly are around caring staff. There is a bit of a double up here. So you'll see that nursing care, there's midwife repeated a couple of times, medical care, staff care. So overall, person-centred care and caring staff are greatly respected and fed back to clinicians. Next slide, please. In terms of getting feedback from the health service providers, on the whole, the health service providers have said what's really valuable about Care Opinion is to get the patient journey in the words of the consumer. It also provides a true sense of emotion and feelings related to those experiences that they may not capture via other mechanisms. It's really good morale boost for staff, as mentioned in the other presentations earlier, for staff to get that feedback. And the stories arrive in near real time, as opposed to other feedback processes that currently occur. The board members and executives across the health service providers subscribe and review stories as case studies in their executive meetings and look out for what's working well and what presents improvement opportunities for change. It's a very easy system to use and it's publicly visible. And there is some level of control. The staff do like that they are able to moderate some staff responses where staff may get a little bit defensive in relation to feedback. So in terms of what consumers have generally said as improvement areas is communication comes out loud and clear. That's repeated a few times here. And also some of the staff attitudes and behaviours are the main things that come out. In terms of the hospitals, the feedback around what their main challenges and opportunities are. So one of the big challenges they're currently facing is that consumer stories are de-identified. And so when they need to respond to a consumer, they feel that their responses often seem quite tokenistic, as they can only encourage consumers to then provide additional detail that would allow them to follow up in more granularity. But this doesn't often occur. And also, while it's great to have individual stories, it can be a bit difficult to identify systemic trends and issues across the system. It's also quite difficult to respond if consumers come in and raise inaccurate information in stories, because they feel that if they go back and try to counteract that, it can seem quite defensive. In terms of opportunities, the hospitals are very keen to increase uptake of care opinion and try to promote it as much as they can without additional burden on staff that are already feeling quite stretched. It would also be good to link existing feedback for trend analysis with reporting dashboard enhancements, which we're looking at currently in WA. And also, it would be good to present other options for those consumers that have limited English proficiency and other populations at risk of lower health literacy. And also, there's a focus on trying to provide training assistance for staff about how to respond appropriately, so that responses can be devolved down to the individual staff member and they don't need to be moderated. So overall, over the last quarter, the resounding feedback has been that consumers in WA across the health system have been very thankful. They felt supported and cared for. Again, there's a double up in the Wordle here of how the stories are tagged. So overwhelmingly, the responses have been positive from consumers, which is great. And now I'll hand over to Tina. Thank you.
Thanks, Fran. Thank you very much, Fran. So as mentioned, my name is Tina Bertolini. I'm the Executive Director for Consumer Experience and Clinical Excellence in North Metropolitan Health Service. We just move on to the next slide. So I was conscious there's people on the call from all over the world, which is awesome, and you might not all realise where we are. So Western Australia, it's a really big state. Tried to map out on this map where our health service sits geographically. You can't even see it because our country areas are actually so big. So we just click through, we'll see where we're situated in metropolitan Perth. So we have a river that runs in the middle of the city and we're in the north, which of course makes sense. Our population covers just over a quarter of WA's total. So a big service that includes one of our 3 big tertiary centres in Metro Perth, a specialist women's hospital, specialist mental health services, dental, and a couple of others. So quite a big service. So we move on to the next slide. So I just wanted to share this article, which is one that I really love, that was published a year or 2 back, which was around the different stages of safety and quality in healthcare, and kind of really links in with consumer engagement, co-production, use of care opinion, and other tools around consumer experience. So it all started with Quality 1.0, which is very much around thresholds, accreditation, standards, and wanting healthcare to ideally follow certain processes and pathways. Then we moved sort of through to Quality 2.0, which was a value add to 1.0, and was really about processes, quality improvement, safety and quality indicators. And then the new movement that we're sort of starting to see really now is around Quality 3.0, which is very much around co-production and looking at healthcare as a service rather than as a sort of a product logic. And that's really about people working together, and they talk about kinship and very much just about consumers and staff sort of looking out for each other within a health service, which I think is a really nice and really simple idea of thinking about quality. So here at North Metro, we've been trying to think about how consumer engagement, co-design and co-production fits in throughout the service in all these different aspects. So the first one is really around strategy. And so that includes things like partnership frameworks. So at North, we've got a partnership model that will be shortly launching publicly early next month, which is awesome, and is really just the first step in our journey towards greater consumer engagement and co-design within our service. Then the next step is really around governance. So looking at having consumer representation on our board, our executive committees, and other relevant committees throughout the service so that we get greater consumer participation. And of course, our community advisory councils and standing those up and getting them really involved in all the different aspects of safety and quality within the service. So I was really struck a couple of months back. I went to the ISQA conference in Seoul, which was all about co-production. And they did a bit of a survey of participants who were sort of from about 80 countries all over the world. And it was quite interesting to see of all those people that had attended that conference, it was 16% of those countries that had consumers currently sitting on their major governing body or their board. So it really just demonstrated that collectively we've got a really long way to go in this space and we're just at the beginning. So then capability is the next step, a very big topic of discussion in S&Q over in WA at the moment. And that's around, firstly, for when we get consumers involved in our health service, making sure that they have the skills and that we train them up and we don't just throw them in the deep end. So things like getting consumers involved on our clinical incident review panels, making sure that we're supporting them and providing them the appropriate training. But then also the capability of the staff working within our health service as well, so that they actually know how to involve consumers in quality improvement and projects and delivering person-centred care. Then the next bit is around data collection and analysis. So Care Opinion is one of the tools that we use along with several others in our health service. So we've also got complaints, compliments and contacts through Datix CFM. And we also collect data using the MySay survey, which is the ARPEX tool that many in Australia at least will be familiar with from the Australian Commission for Safety and Quality in Healthcare. And then the final bit, and really the most important in my opinion, because it's where we actually make change in the service, it's all about QI. So how do we loop in this data to actually drive change in the service? And rather than having just lots of dashboards and lots of information and lots of words, and not really knowing what the themes are or what we can do with it, how can we actually drive change in a logical way? So this is just a bit about how things are looking in our service at the moment. So in terms of inputs, all the various methods of data that I've mentioned, as well as strategic priorities coming through from our consumers, CACs, board exec and Care Opinion. And then the big thing here really being about how do we use these outputs to drive QI, which I think is the million-dollar question and is where we're going to see real change. So not just collecting data, but actually using it to drive improvement and at all the different levels. So at the hospital level, at the health service level, and at the individual care level to the teams that are actually delivering the care. So some of the big challenges in this space, I think the biggest one when looking particularly at sort of the organisational level and how we use this data to drive change is how do we extract the themes from the data and how do we look at the trends and how do we triangulate that up and do it in a way that's not super resource intensive. Ideally, we would be mapping a lot of this information into a couple of simple metrics, and I know that there are other places in Australia that have done work in that space, and we're looking to do the same. But really about just using that information and driving it and using it for action. So there is a really good article about the use of Care Opinion and natural language processing, which is just on the screen here for anyone that's interested. That was really just about how you can use some of the newer tools in predictive analytics to pull information from qualitative data and sources like Care Opinion, and an area that we're looking at also over here. So just another really important point around use of data more broadly. So in terms of triangulating and remembering that when we see really good high-performing health services, we tend to see really good staff experience, good consumer experience, and good clinical outcomes all coming together. So just the importance of using all of that information and sort of driving change by triangulation. And then finally, just onto the next slide. In terms of the future for North Metro here, we're almost working towards full consumer engagement and participation in some of our key committees, so our exec committees and board, as well as committees on the floor. Then using that to really start to drive many of our sort of business as usual safety and quality activities to include consumers. So lots of the things that we do day to day around safety walkarounds, local QI projects, clinical incident reviews, and getting good consumer participation in all of those different services. Then making sure that we focus on capability as well, so that our training is designed and routinely offered to consumers as well as clinicians. Then the themes and trends, so having ways to regularly pull that information from all the qualitative sources that we have, like Care Opinion, Datix, and other sources, and then having ways so that our CACs can review those regularly, our exec committees can review them regularly, and our clinicians can see them and get their own sort of personalised feedback on the ward. And then finally, and most importantly, QI initiatives, and linking that all in with everything else, so that we're tying in the information that we're getting from our consumers and from the service to actually drive QI. Thank you.
Thank you, Tina. Oops,
Thanks, Claire.
sorry.
No, that's all right, Claire, go.
I know we're short of time, and I know that at least 2 people will be able to understand what I'm saying if I talk really quickly, but I'll just try and talk at a pace which is still comprehensible to anyone who might not be from Scotland. Okay, so Health Consumers Council is an independent charity, non-government organisation established almost 30 years ago to represent or speak up for and be an independent voice for consumers and the community on all aspects of health and healthcare. And I won't go through every word there, but our vision really is of person-centred care, and that is equitable. And we do that in 3 main ways. And I'll put our websites on the end so you can have a look on that. But I think the main thing I would say with regards to Care Opinion, I've been there for 5 years. We have had Care Opinion, as you've just heard, a bit longer than that. And what I know is that the role that former staff at Health Consumers Council really played in advocating really strongly for Care Opinion to be embedded as a mechanism for providing feedback to health services because of its transparency, because of its ease of use, and because of just the fact that, that openness that people can have a conversation online and see what other people are saying. So next slide. I'm just going to touch briefly on how we see in Western Australia working with consumers, carers, families, people with lived experience and community members is changing. Next slide, please. And this is just a bit of an overview about some of the roles. So generally speaking, I would say that we're moving on from a paradigm which is that bottom right-hand corner. So people as service users, people who've experienced healthcare or have not had the chance to experience healthcare if there's access issues. So in that, like I say, a consultation paradigm, we're going to either ask you what you need from a service, or we're going to ask you what you think of a service, and that will be used to improve health services. But what we're really starting to see more, and in fact, just this morning, I had a conversation with some of our consumer leaders across the state and was hearing really encouraging feedback that people are now moving much more into some of those other quadrants. So much more into service improvement, the opportunity to be involved in identifying the need for particular improvement projects, helping to scope those projects and being active partners in the implementation of those projects. As well as we have had consumer perspectives on some of our HSPs, and there's an opportunity for us to keep looking at how we do that. And we're encouraged by the conversations that we're hearing across the state about opportunities for lived experience positions or consumer positions in paid roles at senior levels. And one of the things that I've taken from my experience in the UK was when I worked at the health department in London, and they had a patient and public involvement czar. That was the public name for it. It was Harry Caton at the time, and his role really was to champion patient and public involvement, as it was called then. We would call it consumer or lived experience involvement at the highest levels of government. And so that's the kind of ambition that we are having conversations about here in Western Australia. What I would say, and to echo what Tina has just said about that question about the training and the capability, what we do know is the need and the opportunity for building capacity amongst community leaders, particularly if you want to make sure that consumer roles are addressing the issue of equity, because understandably, some consumers who might come forward to be involved in some of these roles sometimes do that because they have extra time or surplus capacity. Not always, but sometimes. And so a key thing is making sure that we're being really intentional about reaching out to groups in the community for whom coming forward to be part of, for example, a consumer committee might not be something that they even know is a possibility, and supporting them with training to make sure that they feel confident and capable to speak up and then step into some of these other roles. So I'll move on to the next slide. And I'll just really finish off by saying that providing the feedback is one thing. I think we've heard some great examples from James and Fraser this morning about how people who've been working with Care Opinion platform for a lot longer have really been able to take, and that's a bit of a flippant image on the right-hand side, but that consumer input that is shared with the system. But what you need is an equal and opposite willingness to listen and act on that feedback. And I think that that's something that I see consumer reps and consumer leaders being able to really support within the health services, to continue to partner with people who work in health services to take those stories and that feedback and be part of translating that into change. And that's how I think that we will see that transformation. And I say that's what some of the next iteration for Care Opinion that we see here in Western Australia. And I just finish by saying that Care Opinion is listed, we're all working to a really significant blueprint for transformation called the Sustainable Health Review, and expanding Care Opinion is named as one of the objectives under one of the recommendations in that report. So it's really recognised as being a real lever for change. And that is all. Thank you.
Wonderful. Thank you very much to our heroic change agents, our consumer advocates from Western Australia, for sharing your experience and for being long-term partners in this journey with us, and also accompanying the rest of the nation to join the Care Opinion community and to elevate the human experience. We don't have time to take any questions, but we've noted them and we'll come back to them. No question will be left unanswered, and if it's not answered today, it will be answered and distributed. It's a really good segue now to go into introducing our next sensational presenter and advocate, Dr. Anne-Marie Hadley, inaugural Chief Experience Officer at New South Wales Health, who will speak to us more about elevating the human experience. Anne-Marie stands as a steadfast advocate of kind and compassionate leadership. Her unwavering commitment revolves around the profound aspiration to craft extraordinary experiences for each individual who crosses paths with New South Wales Health, with a profound awareness of the intimate connection between the well-being of staff and the satisfaction of patients, families, carers, and the broader community. Anne-Marie champions the cause of fostering a culture characterised by kindness and empathy within the health care sector. She ardently believes in the importance of enabling our amazing workforce to consistently offer the highest quality experience with each interaction. And while Anne-Marie wears numerous professional hats, Over the last 40 years, her most cherished and impactful roles are those of a daughter, a mother, and an endearing title of Glammy to 4 delightful glam babies and 2 blossoming glam teens. Wow.
I love Anne-Marie. She's so good.
Very, very welcome, Anne-Marie.
Thank you, Tina. Thank you so much for the very kind invitation to speak with you all today. It's always an absolute privilege to join my many friends in the Care Opinion family, and to Alicia for pulling this wonderful program together. Alicia's very kindly agreed to drive my slides. I am in a seedy, I won't go into too much detail. I'm in a seedy hotel room in Melbourne with variable Wi-Fi. And so I do apologise. I've been dropping in and out. So if I do disappear, it's not that I'm not interested. It's just the cheap hotels that New South Wales Health puts you in. So next slide, Alicia. I can't go past by just acknowledging what a very difficult time this is for so many people across the world, and no more so than in the last few weeks within Australia. And despite the decisions that have been made here in Australia, I would, as always, like to acknowledge the traditional owners of this beautiful lands that we're meeting on today. This is an amazing artwork by a Ministry of Health staff member, Leona, and it shows the 23 disciplines that together connect the New South Wales allied health workforce. So 23 different allied health professionals. And I just think this is a really stunning image that connects me back to my own roots on this land. Not as a member of the phenomenal allied health workforce, but as a clinician who's worked very closely with these amazing professionals. Next slide. I'd also like to acknowledge and how timely and how important it is to acknowledge New South Wales Health, but also my appreciation for our amazing consumers, patients, carers, supporters and loved ones, and the voices of people, as we know, with lived and living experience is so very powerful. And their contribution, and any consumers joining us on the line today, is critical for any health system change. And we embrace that through the use of Care Opinion. This is going to be a very quick whistle stop, just to give you a brief overview of some of the work that's underway across New South Wales to elevate the experiences of our people, our patients, our consumers, our families, carers, and our beautiful volunteers and our amazing staff. I hope that I am an authentic person, and I feel very strongly about honesty and transparency. I'm very lucky to work within the ministry, and I've worked in various roles across the last 40 odd years working in health. And I have to say, I'm very fortunate to be you can develop as many strategies and guidance and policies and procedures, but critical to that are having really strong leadership. Not a tick in the box, we need a strategy around patient experience or consumer experience, but people who really get it. And I have that both in our new Minister for Health, Ryan Park, Susan Pearce, who's the Secretary of New South Wales Health and actually created my position and was the Deputy Secretary of Patient Experience, and my boss, Deb Wilcox, who's the new Deputy Secretary of Health System Strategy and Patient Experience. Titles are really important, but they are actually the actions that really matter. And these people role model the type of culture we wish to see every day. And I truly do believe that New South Wales Health is committed to delivering not only world-class care, but that's also about delivering excellence in the experiences of our patients and families and our staff. So in 2021, I was working actually in Melbourne, here in Melbourne at Monash Health. And I received, first little glam babies were being born, and I was desperate to get home. And I got a phone call and said, oh, I hear you want to come home. Would you like to come home for 3 months and help us develop a patient experience strategy? I said, yep, that's fine. That was 3 years ago. That was the development of Elevating the Human Experience, our guide to action. We developed that. I'm very proudly to say we developed with hundreds of staff and consumers. It was, as you do, develop something like this in the middle of a pandemic. But it really was an invitation to our frontline, to our consumers, our families, about a shared goal of providing consistent, compassionate and kind care across New South Wales to every person who came in contact with us. Following the publication of the Guide to Action, and look, it's not perfect, but it really put a line in the sand and publicly declared our system's commitment to doing better. And from there, we developed 7 enabler working groups that really are, I think, it's not rocket science, of course, but it really demonstrated that there's not one way of delivering. It's important that, as I mentioned earlier, that you've got the leadership, that you've got the culture, that you've got collaborative partnerships, you've got information, you've got technology, and you've got environment and hospitality. One aspect on its own or one enabler on its own won't give you that experience that you wish to see. It's a combination of all of those lenses, and always needs to be underpinned by quality and safety, by change, by policy and procedure, and by coaching and education. Next slide. As always, what comes along, you've developed the strategy or the guide to action, and then in parallel, New South Wales Health was also developing what we call Future Health. And Future Health, I'm proud to say, is it's what's going to guide us over the next decade. And I'm very proud to say that the Elevating the Human Experience is fundamentally centerpiece of Future Health. So at the end of the day, what Future Health is not only recognising the importance of positive patient and carer experiences, but also that our workforce is engaged and well supported. At the end of the day, we are all just human beings caring for other human beings. Next slide. As I said, I've only got 10 minutes, so just wanted to just share with you briefly the 5 focus areas that we're working on over the next 2 to 3 years. You'd be happy to hear that we have got a state strategic approach to self-reported information, to feedback, and the complaints process. At the heart of that are the principles about reducing burden on our patients, families and carers. We have evidence that one patient may receive a request to provide feedback up to 7 or 8 times on one occasion of service. So we're looking to streamline our data collections and really move to a culture of service recovery, and be very clear on the governance and the accountability that sits around that. And definitely looking to the amazing work of South Eastern Sydney, who've long really led the way in using care opinion. But we're also spending, and again, the focus areas have come from the mouths and the voices of our staff and our patients and carers. So we're doing significant work on discharge planning, discharge coordination, transfers of care. We're about to establish our first statewide health literacy hub to really drive a health literate culture. The thing, and Tina mentioned my passion for compassion and kindness. One of the reasons I'm actually here in Melbourne is the Compassion Revolution that was held the last couple of days, and the Gathering of Kindness, which kickstarts on Sunday. And our real emphasis on consumer partnerships and embedding the principles of collaboration and co-design. And we're really looking to mature. We're doing some things really well, and in other areas we can absolutely do better. And one of those is by actually lifting the consumer voice across the system and seeing how we can, as others have mentioned, not only talk the talk, tick the boxes for national standards, but truly embed our consumers into everything that we do. Spending a lot of time embedding staff experience leads across our state, embedding Schwartz rounds, an amazing wellbeing program that we're rolling out to 20 of our hospitals across New South Wales. We're also doing some, I think, some very thoughtful and contemporary work about how we can improve the visitation experience for our visitors, our patients, and also our staff. Next slide, and I know, Alicia, I'm probably out of time. I did want to highlight all of us. This is it came out of the Enabler working groups, particularly out of the governance and leadership enabler and collaborative partnerships. This is absolutely, I'm so proud of this resource. As I said, called All of Us, which named by our consumers, our carers and communities. It's not a document, it's a website. The details here, and I'm sure the slides will be shared. It's an extraordinary piece of work that has been co-designed and really sets the benchmark, I believe, for meaningful and kind engagement with consumers and staff. Hand in hand with that, we've also just recently published the first statewide guidelines for all consumers to be remunerated and reimbursed across New South Wales Health. So probably one of the most polarising pieces of work that I've been involved with, but I think, again, shows true leadership and commitment at a New South Wales Health level. I might finish up there, Alicia, because I know we're running out of time, but I would really encourage you. You know, we are in a bit of a crisis. We're asking so much of our staff, and there is significant burnout. We have so much that we can do to support our staff, to provide that better, the patient experience that we all aspire to provide. So I would encourage you to look out for the Gathering of Kindness, which is held across nationally, held across Australia, go figure, but also in New South Wales. We run the Gathering of Kindness from the 13th to the 17th of November. It is open to everyone to attend. You don't have to be in New South Wales. We're running a fabulous, great debate. Is kindness soft and fluffy? With some fabulous, fabulous speakers. And also we've launched Kind Lab. So a bit of our innovative approach to a Shark Tank, but with very kind sharks as judges. And we've had hundreds of applications from staff and consumers about their ideas about creating a kinder healthcare system. So thank you again for the very kind invitation to speak today. And please, if you've got any questions, put them in the chat. Happy to answer them at any stage, or just reach out, and more than happy to share with you the wins and also some of the challenges and share those with you as well. So thanks, Alicia and team. I really appreciate the invitation.
That's
Wonderful. Thank you
absolutely
so much.
fantastic.
Thanks, Anne-Marie, for your presentation and for, as always, being that inspiring national leader and advocate for consumers, but also championing that role of kindness and care, and which is so important, and how consumers' voice can be lifted across the entire system. I think showing us how that has started to occur in New South Wales by embedding the different programs, initiatives, mechanisms, systems, processes, so that we are able to see that positive impact at the grassroots for every individual, every consumer, and how we do this alongside supporting our workforce, which is really important and for us to be mindful of. So now we turn our gaze to Victoria, where the use of the Care Opinion platform has increased across rural and regional Victoria in the last few years. I have the pleasure of welcoming our next presenter, Dr. Andy Phillips, Executive Director for Patient Safety from Safer Care Victoria. Andy's presentation will focus on using lived experience in ensuring safety and quality of health services in Victoria. And Andy's role in Safer Care Victoria is to reduce preventative harm in healthcare. Andy has worked as a healthcare leader in 6 countries over 3 decades, including the Department of Prime Minister and Cabinet in New Zealand and UK National Health Service. Andy worked on the first national health plan for New Zealand and the New Zealand Charter of Values for the health system. He spent 8 years working to improve the quality of healthcare, particularly for Indigenous communities. Andy will share with us today how using voices of people with lived experience helps assure safety and quality in the Victorian health services. Welcome, Andy.
Thank you very much, Tina. If I can move to the first slide, maybe. And just to pay tribute to what Claire was saying about consumer leadership or leadership from people with lived experience, and also picking up Anne-Marie, the importance of kindness. We're actually running a co-design session on mindful kindness at the Gathering of Kindness on Sunday. Alicia, do we have my slides, or do I need to try and find them on my computer?
Sorry, Beck's sharing for me. So, because I'm letting people into the waiting room. Here they come. Thank you so much, Beck. Sorry, Andy, please proceed.
Oh, great. What a lovely photo. Thanks very much. So if I can move to the next one and just acknowledge country, I'm in Naarm, which is the land of the Wurundjeri people of the Woiwurrung language group of the Kulin Nation. I'd like to pay my respects to Aboriginal elders past, present and emerging. I'd like to acknowledge that this was and always will be Aboriginal land, and also, again, just to acknowledge that the outcome of the referendum a little while ago was not entirely positive for Aboriginal colleagues. So if I move on to the next one, and really just to talk about the fact that as we blend people with lived experience, people who have a clinical understanding, people have a management or governance understanding, this makes what we're doing a lot stronger. So drawing on our differences really makes us a lot stronger. I'll keep returning to thoughts about that. And if we just move on to the next one. So these are the 4 things that I'm charged with. I didn't quite get the introduction right. So my role is about preventable harm rather than preventative harm, but preventable harm. So I'm trying to do 4 things. The first thing is just try and use an understanding of where things have gone right, where we've got some great lived experience of where things have gone right. Try and make those things happen more frequently across the health system in Victoria. Second thing is where things have really gone wrong, use those patient feedback as gold for people to improve services so that things go wrong less frequently. And then the third thing I'm trying to do is where there are serious concerns about that things are likely to go wrong in the future, put actions in place to stop those things eventuating. And then the fourth thing is using lived experience to co-design services that are inherently safe and of high quality. So if you wouldn't mind moving on to the next one, that'd be helpful. So just some principles. I'll run through these very quickly. So the principles that I'm applying in doing this work, so recognizing that people with lived experience are hugely assets to the system, not a burden, not passive recipients, but really quite key to the not only the design but the delivery of service. And then using an appreciative inquiry approach, just building on people's existing capabilities and starting with what they have and looking for the opportunities to make those flourish. So sometimes we do things like needs analysis. I like to do a strengths analysis. What can a community do, or what can a consumer do? What can a consumer thank you? What can a consumer do themselves? What can the community do themselves, and build on those strengths? So we just move on to the next one. So mutual and reciprocity. It's a mutual and reciprocal relationship. It's interdependent, and people with lived experience are really critical to assuring safety and quality of services, particularly where they have some really strong peer support networks, working alongside professionals. So if we go on to the next one, that would be great. So blurring distinctions. You know, in the health system, we like to set up some distinctions, don't we? We like to have our uniforms. We like to have our language that people can understand. We like to have health services, it seems, that nobody can navigate easily. And I think we need to change that and challenge that and blur the distinction between professionals and people with lived experience. And I'll come back to this theme time and time again. The professionals enabling people, facilitating people with lived experience to take up leadership positions. I've had a number of really interesting conversations just this week in Victoria about things like we had a group trying to set up a steering group for people with lived experience, and we had all sorts of directors and executives and people like that, really important people. Who didn't we have on the committee? Well, we didn't have anybody with lived experience on the lived experience committee. And I had another consumer or person with lived experience working with us this week, really challenging some of the ways that we think about how we employ people. So, for example, in our position descriptions, we often have the requirement for people to have clinical qualifications, or we have the requirement for people to have management and leadership experience. And this person with lived experience really challenged us on that and said, well, where in your position descriptions are you requiring people to have lived experience? Because if you just have people who have clinical experience or management experience in these roles, they come from a particular perspective, and that's important. But where's the perspective of lived experience in roles? If we just move on to the next one, that'll be helpful. So I'm trying to work with three types of stakeholders, or 3 Ps. So people with lived experience, providers, and people who pay the bills, the people with governance experience. And really just using each of these perspectives all the time when doing this safety and quality work or co-designing services, really quite important. We'll move on to the next one. So this is a framework that I designed over about 20 years of how I work in co-design and co-creation. And I've used this at the level of an individual patient-clinician interaction, and also for designing large-scale health systems, such as the health system in New Zealand. So there are some very specific parts of it. The first one is how you prepare people with lived experience, how you make sure that they come into the conversation or the work with the same type of knowledge that people who are professionals or who are payers. How do you make sure that we bring people on an equal footing? So there's a preparation phase. The second thing is we really want to know what the agenda of people with lived experience is. What is it they're trying to achieve? How is it they're trying to live their lives? And that's really the key thing that we often miss in these conversations. What is the agenda that people with lived experience are bringing to this conversation or discussion or piece of work? And then quite often there's a need to, when we've got people together and we've found out each other's agendas, quite often sometimes a need to get some more information. And then when we have that information, we're fully informed, we can come and discuss options. And in a patient-clinician interaction, we might have something like an options grid. If we're doing large-scale system design, we might have had some information from a large survey or other form of understanding lived experience, which give us a lot of information about how to inform choices. Of course, then we need to agree the way forward. Then we need to make the change. We need to review the outcomes. But all of this is always informed by improvement or innovation and audit to make sure that we're actually getting the impacts that we thought about. Very often in the quality and safety work that's been done for many years, this aspect of impact assessment has really been left out. So you do some recommendations, you do some actions. People very infrequently look at the impact of the work that's happened. Let's just move on to what I think is probably the last slide, or maybe one of them. So this is the sort of ways in which we've used this approach in Victoria. So this is where we've put our money where our mouth is. So we've had some parents who've had extremely tragic experiences where they've lost their children. Their children have unfortunately come to preventable harm, or they've unfortunately died as a result of some things that have happened in the health system. We have this program that we're calling Safer Care for Kids, and it's the parents with lived experience who are designing that program. They're not just involved or consulted, they're actually designing that program. So we have somebody who has a background of having a child who's very unfortunately been harmed by the health system. That person is paid to lead the program. And then we have a whole group of parents who are coming together as a group to provide the design principles. So they'll be designing the program, and then it will be up to us to, apologies, then it'll be up to us to put that into place. So it's really people with lived experience designing the programs that people like me, professionals, are then required to put into place. Another thing that we're doing is we're using people with lived experience to lead the most important and serious reviews of the systems. So in Victoria, we have this system of autonomous governance where each individual provider, we have 76 of them in the public system, they have their own autonomous governance system. We don't have central control, we have autonomous governance. And from time to time, we need to go into those organizations to take a very serious review of how they've been delivering their services. And what I'm trying to do now is make sure these, for the most part, are led by people with lived experience. They're the team leaders, they convene the team, they do the management of the team. Maybe I could talk a bit about the safety and quality minimum data set. One of the ways in which I'm trying to assure the quality and safety of services across the system is to set out a set of data. We have 36 different data items in 6 domains using the Institute of Medicine and 6 domains of quality. So safety, timeliness, equity, effectiveness, person-centeredness, and productivity. And these data items have very much been co-designed by people with lived experience, and they have lived experience into the domain. So one of the domains is if there's been a serious concern expressed by people with lived experience, that's a really interesting flag for us then to go in and look at the system. Looking at patient stories, so very often we're now using patient stories to influence design of treatment pathways. And when those experiences are from Aboriginal and Torres Strait Islander people, or they're for people with culturally and linguistically diverse backgrounds, then we know that we need to design services in a different way. As Tina introduced, I'd done a lot of work with Maori and designing kaupapa Maori patient pathways in New Zealand, and now just trying to work with Aboriginal people and people with culturally and linguistically diverse backgrounds to see the world from their perspective. I had a conversation today about this, about how we look at cultural safety. So this is a talk about safety. My strapline is there's no safety without cultural safety. And I could come at this from a Western medical paradigm and say, well, what I need to get a reporting system about cultural safety issues, and I'll build into my systems. But my experience with Indigenous people says that that's not often the way that Indigenous people deal with these types of issues. So I do want to work with people from those backgrounds so they can design the system rather than commenting on the system that I've designed. We're very much using the information we get from care opinion and other types of feedback mechanisms to provide some learning for services along the lines of those 4 things I talked about earlier. And then the last thing I'd say is we now have very important consumer input into multi-agency reviews. Healthcare is often very complex, and unfortunately patients come to preventable harm if they interact with that complexity. So I think what I'd say in summary is I very much agree with the comment from Anne-Marie about kindness. I think it's about mindful kindness, and I hope some colleagues will come and help me co-design that mindful kindness or kindfulness at the gathering of kindness. And it's about moving people with lived experience into leadership positions so that they can lead us, they can take their leadership part alongside us, and not just in honorary type positions, but actually in paid leadership positions where their skills are as valued as people with governance or clinical skills. Thank you very much, Tina.
Thanks so much, Andy. And the Care Opinion team will also be at the Gathering of Kindness event in Victoria, as we have been in the past couple of years. Really a wonderful network and group of keen leaders looking at this movement across the nation. So very keen to be able to join that space. Thank you for your presentation, and your wealth of experience and leadership is vital for the broader implementation and uptake of Care Opinion across Victoria, Andy, and amplifying the consumer voice and improving quality and safety across your state. We will now transition to our next presentation. So Care Opinion as a data source for evaluation, the experience of the Prince of Wales Hospital. When we introduce Care Opinion, we often say that we are more than a data source, but it's important to recognise that qualitative feedback does have value as a data source, particularly where it can be collected, responded to, and or acted upon a real time. And I'm delighted to introduce a presentation from one of our longest serving Care Opinion Australian subscribers, the South East Sydney Local Health District. Presentation by Justin O'Hare, who is the Co-Director of Nursing and Operations at Emergency Specialist and Continuing Medicine at Prince of Wales Hospital. Joining Justin is Francis Nicholas. Francis is the Service Manager for the South East Sydney Local Health District Community Management Centre and the Virtual Health Platform for the Health District. Justin and Francis will share their experience of using Care Opinion as a means for engaging with consumers in the most challenging of times and evaluating service redesign through feedback stories at the Prince of Wales Community Management Centre. Thank you both, and very welcome.
Thank you. Thanks everyone for having us here today. We'll just go to the next slide. Thank you. The next one after that. Just a bit of a background. So the Community Management Centre at Prince of Wales Hospital is currently now transitioned to be the virtual health hub for the district of South East Sydney Local Health District. But prior to that, if we're setting the scene in September 2021, during the Delta wave of COVID, the district, we needed to really set up a service to be able to, tend to the needs of our adults in the Cecily community that were with COVID-19 due to the hospital presentations and whatnot. So we upscaled a remote monitoring service within 2 weeks. And that was utilizing a smartphone app, which we had trialed through Total Cardiac Care earlier in that year, but that essentially monitored our patients for their pulse oximetry, temperature, and had a well-being questions with that. So we set that service up within 2 weeks. And this led us through the multiple ways of COVID, monitor our patients, particularly the high-risk vulnerable patients at home, allowing them to stay at home during the isolation in the various lengths of what that became, but then also navigating their care through the primary health network, their specialists and whatnot, through the remote monitoring and through the CMC. So during the peak, we saw 12,000 patients come through, and then after that, this year we've transitioned into monitoring our heart failure patients at Prince of Wales, and like I said, it's now moved into being the virtual health hub for the district. So if we go to the next slide, as I said, due to the rapid need during the Delta wave, there was really a lack of co-design with the service, because we had to really set up on the go really within 2 weeks. But after 5 to 6 months, we looked at opportunities of how we could, engage some more feedback from patients. Also, when staff were contacting patients, we're getting informal feedback, which we would acknowledge, and that was through when we're doing daily calls and wellbeing checks. But we thought Care Opinion would be a great source to get feedback from. Part of our processes is everyone that was onboarded would get sent out in a courier that day a pulse oximeter. So we thought, why not put on the care opinion sticker to the, the hundreds of pulse oximeters we're sending a day. So if we go to the next slide, probably the one after that, you can see, so from May, it was really the end of March, we did it from May to September, where there was some peaks, those real peaks last year in 2022. You can really see we had, 5, 18, 11, 10 care opinions a month come in, where there was stages there during that winter part of the year where the co-director in my role at the time was having trouble keeping up with the meeting the KPIs for the responses to it. So we got a lot of good feedback from it. 99% of them were positive that come through. A vast majority from the patient themselves, but then also we got some throughout the from other clinicians as well. But we out of the positive feedback we got there, we also got some good suggestions and what we can do in regards to the service to tailor it to the patient, because there was being high-risk patients, there's nuances in each type of patient that would come to us with the level of risk with the comorbidities that have. But we learned a lot from what we got from care opinion and how we modified our models of care as we've continued to go along. But it also helped us with shaping us moving into the heart failure space, and then also now moving into the virtual health hub for the whole district and moving on from there. So I'll pass on to Francis now, who will talk a bit more.
Next slide, please. Good afternoon, everybody. My name is Francis. I'm the acting service manager of the Community Management Center. So it's a district-wide service hosted by the Prince of Wales Hospital. I am now going to present to you 3 patient feedbacks. And this first feedback will talk about an immunocompromised high-risk patient who has been in a service for 2 weeks, and also highlighted that she is being cared for. And it's also highlighted that care opinion is transparent, convenient, and can provide real-time patient feedback. It's also measurable, and it gives us an accessible access to everyone, which also allows users and providers to connect. As you can see, we were able to respond on the patient's feedback on that end. And also on that feedback on the second real-time response it's actually a staff member who has been on our service and given a feedback to our service, because he felt that it was very touching, and it's very heartwarming, it's very personalized, and we were able to feedback that evaluation to the staff itself and also to our managers. So next slide, please. Up. So going back again, would you be able to go back on the next slide before that? So this feedback is also an example as well of a high-risk patient, which actually on our service, but on a different hospital, but on the same local health district, with actually given a good feedback. But also if you can scan it through the first 2 or 3 sentences, it's actually the patient has given a feedback that there's a lot of processes happening on the time, because the patient went to ED, went to talking a lot of different people, but it also serves us as a linkage to different local health district to communicate the care that we provide and the feedback that we needed to know as a health service in general. So this shows that care opinion benefits the Southeastern Local District in terms of getting the patient's experience. So next.
And if I just step in on that one there, I think the key to that is at the community management center was ideally a nurse-ran service, so we didn't have a specialist actually in the service. So we utilize that type of feedback to be able to link patients with their specialists, their GPs, they're treating clinicians and things like that to prevent hospital admissions and make it more linked outside in the community. And we actually had a 3% ED presentation rate for COVID since we've been operational. So I'll let Francis keep going.
Yeah. Thank you, Justin. So looking at this, I believe that, and our service believe here at CMC, that care opinion empowers. It says in here 55 stories has been told, but we're not focusing on the numbers, but we're focusing on the moments that we have experienced with the patients. And we are able to continue that until today as the newly established remote patient monitoring service in our local district. So that is one of our patients for our remote monitoring team. So next slide, please. So I also wanted to highlight that Care Opinion cares not only for the patient itself, because I know Care Opinion talks about patients, but here at CMC, I managed to collect all the Care Opinion Hero Certificate Awards from the time that we started, and I individually deliver that to each and every staff that has been mentioned to Care Opinion. This serves as a boost of staff morale, and also during the urgency of and the busy times of COVID-19, I think the best thing that we could do is to recognize the staff members, the times that they're spent with a patient, being a ultimate support during COVID, and not only during COVID, only that phone call that really supports patients at home, and they felt that they're being cared for. This also increases the workforce engagement regarding the staff. And I think Dr. Annie had mentioned a while ago about compassionate leadership. So this is, I think, compassionate leadership that we should echo within our staff members. So yes. And as part of Care Opinion, I have asked a few members of our team here at Care Opinion at Community Management Center, what do they think about Care Opinion? So these are the few feedbacks that they have given me. So I'll give you a few seconds to look at it. And I do believe that Care Opinion and also triggers or supports the well-being of the staff members, because I do think it works hand in hand. Care Opinion empowers, and also not only empowers the patients, but also empowers the staff member, because I do believe staff acknowledgement is very important in supporting patients' live experiences. Next slide, please. Questions, maybe later on. Next slide. And the next slide is the care continues here at the Community Management Center. Thank you very much for letting us present here in this event.
Thank you very much, Justin and Francis, for sharing with us examples of some patient feedback and how you use the real-time data for empowerment and other positive impacts. And also very fascinating and invaluable to see the staff feedback for Care Opinion, which is increasingly being done across health services. As you know, having a platform like this, wanting to implement something that is embedded within a system requires a cultural shift, and having the workforce engaged and providing feedback is very important. So great work with that.